and now we have another really difficult task, which is pancreatic cancer. Olaparib show a new promise for a difficult clinical situation, which is pancreatic cancer. We are very glad to have Professor Dr. Emad Hamada, the Chair of Clinical Oncology in Qasr Aini University, Qasr Aini Faculty of Medicine, Cairo University, and Dr. Hamada, you miss very nice weather here in Alexandria, and we miss you so much.
Thank you, Professor Abdesalam, and congratulations for the annual ACOD conference. And actually, yes, I miss a lot, but definitely I have commitments, so I'm very sorry to not attend the ACOD this year, but inshallah, I will promise, inshallah, that I will not miss it again. And also, I would like to congratulate you to be the chairman of the Clinical Oncology Department at Alexandria, and definitely, my task in the next few minutes will be on prostate cancer and not the pancreatic cancer. So definitely, what about, did we need any unmet need for the prostate cancer in the metastatic castrate-resistant, yes or no?
تفضل دكتور عماد.
You hear me?
Yes.
Okay, so I will start by the profound in the personalized medicine era for the metastatic CRPC. This is my disclosure, and definitely we are in need to improve our standard of care for men with metastatic CRPC, because definitely we have in the last 5 years multiple systemic options that can be considered for the treatment of the metastatic CRPC, but definitely we do not have an optimal sequencing, and still the outcomes remaining poor. And by this, we learn a lot from the post-Docetaxel data in CRPC patients, where we have approximately 4 drugs that have improved our overall survival, starting by the cabazitaxel, the abiraterone, the enzalutamide, and lastly but not least, the radium-223. What is very important to hear that although we have an improvement in overall survival, but most of these drugs have been compared to placebo unless the cabazitaxel was against the mitoxantrone. So definitely the clinical landscape is very dynamic, and the new hormonal agents established for the metastatic CRPC as the taxanes and the also the new hormonal agent as ABI or ENZA are moving into the earlier treatment lines. So definitely for the metastatic CRPC, if we use all these new hormonal agents in the metastatic hormone sensitive, we are with 2 only drugs, the cabazitaxel and the new generations for the PARP inhibitors. By this study in the cabazitaxel versus enza or abiraterone, definitely we have for those patients with germline homologous recombination defect poorer or worse prognosis when we use the cabazitaxel. So in order to use the cabazitaxel, should we go for homologous recombination repair gene alterations first or not? This small study showed that carry a very poor prognosis for the cabazitaxel. Also, 90% of the metastatic CRPC patients have genomically aberrant pathways involving the androgen receptor, the PI3K, and the DDR and the WNT and the cell cycle related signaling. But if you see here that the most common is the androgen receptor pathway, harboring approximately 71%, and followed by the PI3K 49%, and the cell cycle 32%, the WNT pathway 18%. But what is very noticed that we have approximately 23% of the mutation were identified in the DNA repair pathways. And there was no currently approved biomarker for targeted therapies impacting the other recognizing signaling pathway defects associated with metastatic CRPC. And as mentioned by Professor Ala in the management of ovarian cancer, that definitely the DNA repair pathway is one of the main hallmark for these tumors. and mutations in such repair pathways can lead to genetic instability and may drive the tumor growth. And the key mechanism for the repair of the DNA double-stranded breaks is the homologous recombination repair, while for the single-strand break, definitely it is the PARP. So protein directly or indirectly associated with such homologous recombination repair pathway may predict the PARP inhibitor sensitivity. And definitely we have evidence to date that suggests that prostate cancer driven by the homologous recombination repair mutation is associated with a clinically and histologically aggressive disease. And as you see from this cartoon, that definitely we have some that are have PARP sensitivity and others that do not have PARP sensitivity. And in the homologous recombination deficient cancer cell treated with PARP inhibitor as olaparib, the double-strand breaks can only be repaired using the error-prone pathway, which ultimately leads to the cell death. So what about the rationale for the PROfound study? Definitely olaparib has been investigated as a novel monotherapy in metastatic CRPC by the study 42 and the subgroup for the PARP A that have been confirmed the activity of olaparib in biomarker selected metastatic CRPC. Not only that, but in the PARP A, the olaparib improved the outcome in patients with metastatic CRPC with homologous recombination repair gene defect versus those without these defects. As you see, if you have a biomarker positive, yes, the overall response can reach 87.5 versus 6.1%. And as you see, the median radiographic PFS is very, very widely separated for those with gene defects and those without gene defect. And also we have some trend to overall survival benefit in these patients carrying the homologous recombination gene defect. However, definitely we have some safety profile for the olaparib, as here the dose have been 400 milligram BID tablet. So definitely we have anemia, fatigue, leukopenia, and some thrombocytopenia and neutropenia. So the PARP A contributed to the FDA breakthrough designation in 2016 for the olaparib for BRCA mutation, ATM mutation, metastatic CRPC after taxane-based chemotherapy and more than one new hormonal agent. PARP B also confirmed the clinical activity of olaparib for patients with BRCA and homologous recombination repair gene defects, validating the results from the PARP A. And as you see, the most common gene defects here are the BRCA1 and 2 and the ATM. So the safety also and tolerability of olaparib have been consistent with the previous trials, whether the 42 study or the PARP A. So my first take-home message that prostate cancer is a heterogeneous disease, and about 20% of the patients have an underlying DNA damage repair aberrations. However, there was no approved molecularly targeted therapy based on phase 3 study. Outcomes for patients with metastatic CRPC remain poor, and olaparib target the homologous recombination repair deficient cancer cell, leading to cancer cell death, and PARP inhibitors are recognized as novel therapies to treat tumors with deficiency in such pathway. And we have the study 42 and the subgroup of the PARP A and PARP B that confirms the clinical activity of olaparib in patients carrying BRCA mutation or other homologous recombination repair gene defects. So we are needing to confirm this data by phase 3 study. Came the PROfound, which is the first randomized phase 3 study evaluating the efficacy and safety of olaparib versus the new hormonal agents in patients with homologous recombination repair mutation, metastatic CRPC. And definitely these are the study design where we have two cohorts of patients, cohort A, where they carry the BRCA1 and 2 or ATM mutation, and cohort B, other homologous recombination repair mutations. As I randomized the patient 2 to 1 to olaparib, but look here, the dose is less, 300 milligram BID versus the physician choice, and most of the physician choice have been either ABI or ENZA, and definitely the randomization have been stratified according to which the patient have receiving vaccine, yes or no, have a measurable disease at baseline, yes or no. And definitely they go till BI or blinded independent committee review progression. So, and they allow here definitely the crossover. And they have a primary endpoint, mainly the radiographic PFS in cohort A using the RECIST criteria and the prostate cancer working group 3 criteria. And they have the key secondary endpoint, including the overall response rate in cohort A, radiographic PFS in cohort A and B, time to pain progression in cohort A, overall survival in cohort A, and lastly, the safety and tolerability. So the endpoint in the PROFOUND trial have been analyzed in a very hierarchical procedure. We start first by the primary endpoint, and if the study will meet the primary endpoint, we'll go to the secondary or the key secondary endpoints, including the response rate, the time to pain progression, and the overall survival. So the second take-home message from this trial, the patient randomized to the PROFOUND only needed to have progression on a prior new hormonal agent, and prior taxane chemotherapy has been permitted but not mandated. Patients were stratified by prior taxane therapy, and the new hormonal agent was chosen as a comparator, and the PROFOUND had been conducted as an open label study, giving the different treatment schedule and toxicity for the control arm, and crossover from physician choice of new hormonal agent to olaparib if they demonstrate radiographic progression and were fit to be considered for olaparib. And due to the predicted high uptake of crossover to olaparib in the physician choice of arm, radiographic progression-free survival has been chosen at the primary endpoint, with overall survival as a key secondary endpoint. So the PROFOUND screened approximately 4,425 patients, providing data on the largest population of patients with metastatic CRPC assessed for the homologous recombination mutation. As you see, we started by screening 4,425, randomizing only 387 patients, 245 in the cohort A, 142 in the cohort B, and the global study with patients enrolled in approximately 20 countries. The first patient randomized was in April 2017, the last was in November 2018, and the data cutoff was on 4th June 2019. Also, as you see, we subdivide the homologous recombination repair gene panel 15 genes into two cohorts, the cohort A and the cohort B, cohort A, BRCA1, BRCA2, and the ATM, and the others for cohort B. And approximately 30% of the patients were identified with a qualifying homologous recombination repair mutation in the screen mutation in line with the current literature. And as you see, a similar proportion were identified. It is very important whether the tissue was from the primary tumor or the metastatic deposit. As you see, for the primary tumor, 27% HRR gene alteration, and in the metastatic tumors, we have approximately 32% of homologous recombination repair gene alteration. As I mentioned before, that definitely the BRCA1 and BRCA2 and ATM and CDK12 are the most common mutation identified. So the take-home message, my third, is the PROFOUND has screened a very large number of metastatic CRPC patients and for homologous recombination mutation, and they recruited on two-stage screening process, and we have 15 genes that are selected based on the mechanistic role in the homologous recombination repair and the sensitivity to PARP inhibition. Tissue testing was used for testing as a gold standard for tumor molecular analysis, circulating tumor DNA and germline samples of blood have been collected, and the qualifying homologous recombination repair alteration had been observed in approximately 28% of the metastatic CRPC patient with a very successful tumor test results consistent with the other studies, and the most common gene alterations have been in the BRCA2, ATM, and CDK12. What about the tissue testing? Because all the doctors search for how to do the tissue testing for the BRCA or the gene alteration for the homologous recombination. Definitely, again, it is used by the tissue next generation sequencing testing, and it is very important to hear that the majority of samples assessed in the study were from archived core biopsies derived from the primary tumor. As you see, 89.9% from the archival tumors, and from the primary, it has been 83.6%, and the most common is a core needle biopsy from the metastatic site. But also, the success rates have been higher with what we know as new collected samples and not the archived one. And the samples derived from metastatic sites versus the primary tumor origin. Because definitely the most common reason for test failure in the archived samples have been to fail at the stage of DNA extraction. And also the most common test failure for the newly collected samples have been to fail at the pathology review. But if you see the curves for the archived and newly collected, they are quite comparable. However, definitely the new collected samples are much better, and the primary and metastatic samples are quite the same. So if you take a biopsy from the primary or from the metastatic site, it is the same. What is very important to hear that the core needle biopsy, which is the most common collection method in approximately 3,000 plus patients, had the lowest test success rate, and the higher testing success rates have been from the radical prostatectomy or the transurethral prostatic resection. The majority of samples have been collected from prostatic tissue and over a broad timeline from less than 1 year to more than 1 year. So definitely we have a higher proportion from archived core needle biopsy with varying amount of tissue, and the lymph node sample had the highest testing success if you have a patient with pelvic lymphadenopathy, and the higher testing success rates also have been mostly in the recently collected samples. So do not depend on the archive, and you can go for a newly collected sample. So my first take home message is that tissue testing is recognized as the current gold standard for tumor analysis. The collection method, you can go for core needle biopsy or small residual tissue sample size, but definitely when you go to such a small residual tissue sample size, it have a minimal tissue volume input that can be a limiting factor for a successful test outcome. And also the age of the sample, it is very wide. You can go up to 10 years, but definitely the older samples were associated with a lower success rate. And as I mentioned, that the archival have been in the range of 57% and the recently collected in the 64%. So go to the recently collected, and most samples were from the primary tumors, but definitely the metastatic samples also came with a higher cellularity and tumor content, and definitely we can go for the metastatic side. And the common reason for test failure in the PROfound have been that the samples did not meet the pathology requirements small enough and had insufficient yields for DNA extraction for next generation sequencing. And this highlights the critical importance for selecting high quality samples and optimizing tissue collection to improve the next generation sequencing testing success rates. The baseline characteristics have been generally well balanced between the arm, and also, as you see, with the disease, the performance status, the prior taxane news, the baseline PSA, and the most common are the BRCA2, ATM, and CDK12, were the most prevalent genes for qualifying gene alteration in randomized patients. And we have co-occurring alterations. We can have some BRCA2 with the PALBO, and we have some red with the BRCA2. We have the ATM with the CHEK2. So we have some co-occurring alteration in approximately 2% of the screened patient, with approximately 7% of randomized patients, and these have been mostly associated with either BRCA2, ATM, or the cyclin 12 genes. So the profound had the primary endpoint radiographic progression-free survival, and look here to the curve that definitely the median PFS had been doubled when your patient received olaparib if he had a BRCA1, BRCA2, or ATM, which is the cohort A, versus the physician choice, which is a new hormonal agent, and notice that the randomization is 2:1. So we have a very good hazard ratio of 0.34 and a very good success rate at 1 year, 28% for the olaparib versus 10% for the physician choice. Also, when we go for the subgroup analysis for the cohort A, including the BRCA and the ATM, all have been in favor of the olaparib, whether you have an ECOG performance status 0, 1, or 2, age less or more than 65, and the measurable disease or no measurable disease. What about the objective response rate? As you see from this cartoon, that definitely 33.3% versus 2.3%, a 21-fold increase in the rate of response for olaparib versus the physician in those patients with BRCA1, BRCA2, or ATM mutation. What about the decline of the PSA 50 and the circulating tumor cell for cohort A with overall response? As you see in cohort A, we have a favorable of 43% PSA 50, 43% versus 7.8, and the circulating tumor cell conversion 30% versus 11.4%. So it seems that we have another method for assessing the response to patient using this parameter, the PSA 50 and the CTC conversion, particularly for patients who do not have any measurable disease. What about the cohort A and B, including all the 15 genes? We have some statistically significant and clinically meaningful improvement by the blind independent committee review for the radiographic PFS for olaparib, 5.8 versus 3.5, with a hazard ratio of 0.49 and a statistically significant p-value. So also the radiographic PFS have been in favor of olaparib in cohort A and in cohort A plus B. What about the median time to pain progression? It was significantly increased with olaparib. It is not reached versus approximately 10 months with the physician choice. And we have a very good hazard ratio of 0.44. And definitely this have, if you prolong this, it have a very good statistics on the opioid use and the worst pain item. Olaparib also demonstrated statistically significant overall survival for cohort A. So not only the primary endpoint, but also the secondary endpoint. And we have a very good hazard ratio of 0.69 with p-value of 0.02 in favor of olaparib versus the physician choice, which means we have a decreasing the risk of death by 31%. Also, it demonstrates a final overall survival for alteration with cohort A versus even with the crossover. As you see, for cohort A, the hazard ratio was 0.69. With adjustment for the crossover, it increased the hazard ratio to 0.42 with a crossover rate of approximately 67%. Also demonstrated a benefit in overall survival, but not statistically significant in cohort A and B. However, when you look to the crossover also in this group of patients of cohort A and B, the hazard ratio reached 0.55 with again a crossover rate of 66%. So it seems that patients definitely benefit from olaparib versus the new hormonal agents. And for final overall survival, there was an improvement treatment effect have been seen with olaparib for BRCA mutated metastatic CRPC in patients who had not received taxanes. So definitely, if you have a patient that did not receive a taxane, look to the two curves. We have a hazard ratio of 0.30 versus a hazard ratio for 0.64 for patients receiving prior taxanes. Also, these are the final overall survival benefit for all patients. It is in favor of olaparib, and we have definitely some of the patients that did not, that did not benefit from the olaparib, but definitely this could be due to the small numbers. These are the...
Dr. Ahmed, just 1 minute more.
Yes, okay, it is just 1 minute. There was no significant difference in death due to adverse events, and the median time to first onset for the adverse events were all within the first 3 months and were typically resolved within the first 6 months of treatment. And this is my final take-home message. Then in patients with metastatic CRPC with disease progression on prior new hormonal agents, olaparib provides statistically significant and meaningful improvement of the radiographic PFS compared with the physician choice either ENZA or ABI, especially for patients with alteration in BRCA1 and BRCA2 and ATM, which is cohort A, and in the overall population with alteration with any qualifying gene that with direct or indirect role in the homologous recombination repair. Lastly, the PROfound is the first positive biomarker with selected phase 3 study evaluating a targeted therapy for men with metastatic CRPC. I do believe that you can go for the testing for the BRCA1 and 2 and ATM if you have a patient with metastatic CRPC. If he had this alteration, go for the PARP inhibitors. If he did not, you can go for the Docetaxel. But also, I do believe that in the future, we will have also some alterations, as in the PTEN loss, we have another drug that could be joining the schedule or the treatment options for metastatic CRPC. And thank you very much for your kind attention.
Thank you, Dr. Ahmed, for the elegant presentation. And actually, the PARP inhibitor opened a new chapter for targeted therapy that really changed the task of many clinical situation, difficult clinical situation, really. And we are very optimistic that they will add major clinical benefit to refractory patient and resistant cases. Again, thank you, Dr. Ahmed, and we are looking to see you soon, inshallah. Thank you so much. And by this, I conclude this session. Thank you.